Hello, welcome everyone. Thank you so much for joining us today. We're really glad to be presenting today. My name is Jennifer Noel. I'm the program manager for the Education and Outreach program for the UVM Center on Rural Addiction, and we refer to ourselves as UVM CORA. UVM CORA is also a rural center of excellence on substance use disorder treatment. And I'm joined today by our Education and Outreach Program Assistant, Eleanor Broy, who is going to help facilitate this webinar. So as you are entering the session, you're automatically muted and your cameras are turned off. So today's webinar is entitled Development of a Toolkit for Implementing Evidence-Based Assessment and Treatment Practices for Co-Occurring PTSD and SUD in Rural Healthcare Settings. And it's presented by Drs. Kelly Peck and Lindsey Smith. The Community Rounds workshop series is a live webinar series regularly hosted by UVM CORA. And our goal is to offer opportunities for health professionals and community partners to learn, engage, and ask questions. And we cover topics related to science-based best practices for substance use disorders. And now we have just a couple of things to go over before we get started with the webinar. We do encourage you to ask questions, and we will have a Q&A session at the end of the event. So during the webinar, feel free to enter your questions into the Q&A box, which you may need to, it should be in your black banner on your screen, but you may need to click the 3 dots to get to it, but it looks like what is pointed to there on the screen, the Q&A box. This session is being recorded, and recording will be delivered to your mailbox next week. We'd also want to let you know that after our speakers are done with their presentation and just before we start with the Q&A, there will be a very quick poll to help us with our evaluation. So we hope you don't mind taking 1 minute to answer those questions in the poll. If you would like, please use the chat box to introduce yourself by sharing your name, your organization, and the community that you're coming from. And we're always glad to welcome comments that you may have about the webinar itself, which you can add to the chat. Please be sure to select everyone when using the chat feature so that other participants can see your comments. We are pleased to offer live captioning for today's event, and you can find the link to the captions by checking the chat. We're going to share a link for that. Continuing education credits are available for both those who attend this session live and those who watch the recording within 1 month of the live event. And during the session, we will share a link in the chat box with instructions on how to claim your credits. You will receive these exact same instructions next week in your email when we send you the recording. But if you have any questions, please contact us at cora@uvm.edu. There are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So I'm going to stop sharing now and let Dr. Peck share his screen. And while he's doing that, I would like to welcome Dr. Eli Klemperer, who will be introducing our speakers today. Dr. Klemperer is an associate professor in the departments of psychiatry and psychological science. He serves as the associate director of the Vermont Center on Behavior and Health and is the director of education and outreach within CORA. Dr. Klemperer, I will hand it over to you.
Thanks, Jenny. So I'm very excited to introduce our speakers today. First up is Dr. Kelly Peck. He is the Director of Clinical Operations for the University of Vermont Center on Rural Addiction and is an associate professor with joint appointments in the departments of Psychiatry and Psychological Science at UVM. His primary research and clinical interests are twofold. First, he has conducted research focused on the development and evaluation of novel treatments for opioid use disorder. And second, he has worked extensively to address a co-occurring post-traumatic stress disorder in individuals with substance use disorder, particularly around the delivery and evaluation of cognitive behavioral therapies for PTSD, including a novel prolonged exposure therapy protocol for improving prolonged exposure therapy attendance and PTSD symptom severity among individuals with co-occurring PTSD and opioid use disorder. Next up, we have Dr. Lindsey Smith, and she is the Director of Substance Use Research and Evaluation and a Senior Research Associate at the University of Southern Maine Catherine Cutler Institute, where she is responsible for designing and implementing health services research and evaluating projects related to addressing substance use disorder. She has extensive research and clinical expertise in the area of substance use and behavioral health disorders, which has been the primary focus of her research for over 20 years. She has experience designing and managing research and evaluation projects at the local, state, and federal levels. So with that, I will turn it over to Dr. Kelly Peck. Kelly, it's all yours.
Thanks, Eli. I thought I had the screen share all figured out. I'm going to try this again. All right. Now we're making progress.
Looks good.
Does this look okay? Or did I mess it up? Okay, great. Okay. Well, glad to see everybody today. I'm always really interested to see in the chat who all is here and where people are coming from. Appreciate you taking time out of your day to attend this webinar. So today, Dr. Smith and I will be talking about a UVM CORA project that's been underway for the past couple of years, in which we have worked to develop a toolkit for implementing evidence-based assessment and treatment practices for co-occurring PTSD and opioid use disorder, with a specific focus on rural healthcare settings. As Eli mentioned, I'm an associate professor here at the University of Vermont, and then the director of clinical operations for UVM CORA. And I'm just really excited to share this project that we've been working on over the past couple of years. So the goals of our presentation today are to discuss the co-occurrence of post-traumatic stress disorder and opioid use disorder, provide an overview of evidence-based guidelines for the assessment and treatment of PTSD among individuals with co-occurring substance use disorders. And then Dr. Smith will spend some time describing barriers and facilitators to implementation of these practices that have been identified by rural providers in Maine, New Hampshire, and Vermont. And then we'll close our presentation today introducing our newly developed co-occurring PTSD and opioid use disorder toolkit. So to start off, for those of you who are unfamiliar with PTSD or post-traumatic stress disorder, PTSD is defined according to the DSM as a psychiatric disorder that occurs in people who've experienced or witnessed traumatic events. That could be a natural disaster, sexual assault, physical assault. Trauma can look a lot of different ways. In addition to experiencing a traumatic event, individuals must exhibit symptoms from each of the following 4 symptom clusters in order to meet criteria for DSM-defined post-traumatic stress disorder. So those symptom clusters include intrusion symptoms, so intrusive thoughts about the trauma, nightmares related to the trauma, avoidance of internal or external stimuli associated with the trauma, so avoidance of memories of the event, people, places, and things that might remind them of the trauma. We also see negative alterations in cognitions and moods, so depressed mood, changes in beliefs about the world, beliefs about themselves, things of that nature. And then we also see arousal and reactivity, so that can be hypervigilance, hyperarousal, problems with sleep, problems with concentration, things of that nature. And so to meet criteria for PTSD according to the DSM, these symptoms have to persist for at least a month and then cause significant stress impairment or impairment in important areas of functioning. Then if we're talking about opioid use disorder, for those who are maybe more in the mental health world, if we're talking about opioid use disorder, this is the definition that we're using. So this is a type of substance use disorder that involves a pattern of opioid use. So that could be prescription opioids, heroin, fentanyl, lots of different formulations. That's difficult to stop despite a desire to cut down or regulate use. And then that use negatively impacts one's physical and emotional health, their relationships, and their daily functioning. And so this is, according to the DSM, the sorts of symptoms that we would look for when assigning an opioid use disorder diagnosis. So using opioids in larger amounts or for longer than intended, craving, tolerance, withdrawal, as well as failure to fulfill major obligations due to opioid use. So now that we've talked about how we are defining these conditions, let's talk about prevalence. So as Eli mentioned, my research is focused on post-traumatic stress disorder, its co-occurrence with substance use disorders, and then developing evidence-based treatments for those co-occurring conditions. So on this data is a bit dated at this point, but I think it is a pretty good representation of prevalence. So that orange bar there on the far left represents the percentage of people who have experienced trauma at some point during their lifetime. Trauma is prevalent. The majority of people have experienced a traumatic event at some point during their lives. That yellow bar in the middle represents the percentage of people who have experienced traumatic events who go on to develop PTSD. So we can see here that more than 2 times more women than men develop PTSD following the experience of a traumatic event. And that green bar there on the right indicates the percentage of people who have experienced a traumatic event who do not go on to develop PTSD. So the main takeaway here is that trauma is a common experience, and that many people, despite the experience of trauma, do not go on to develop PTSD. What we're really trying to address is that yellow bar there in the middle, people who experience trauma, who go on to develop persistent symptoms or persistent problems following the exposure to trauma. When you look at prevalence among people with opioid use disorder, you see some pretty drastic differences compared to the general population. So it is pretty well established that the prevalence of PTSD is substantially higher among people with opioid use disorder than what we see in the general population. In fact, almost all patients with opioid use disorder report experiencing traumatic events at some point during their lifetime. And then 1/3 of those individuals go on to develop a diagnosis of PTSD at some point during their lives. And so you can see on this table how that compares to the general population. There was a paper came out a couple of years ago, a large meta-analysis where they evaluated the prevalence of different psychiatric disorders in people with opioid use disorder compared to sort of community samples. And so inside that red bracket, you can see the percentage or the prevalence of PTSD among people with opioid use disorder, which is about 18% according to this. And this is, I apologize, that last slide I was showing lifetime prevalence. And then in this figure, we're looking at current prevalence. So within the past year, 18% of people with opioid use disorder met criteria for PTSD compared to only about 1% in the general population. So the main takeaway here is that trauma is common among people with opioid use disorder, and PTSD is also prevalent within this population. Trying to make things a little bit more local. This is some data that we collected, I guess, 5 or 6 years ago. Just a quick screener that at the Chittenden Clinic assessing some common symptoms of PTSD. And again, the Chittenden Clinic is the largest MOUD provider in the state of Vermont. According to the survey that was administered to people at intake at the clinic, 94% of patients endorsed at least one PTSD symptom at intake. And then 61% reported experiencing a traumatic event at some point within the past month. And that number really still is kind of astounding to me every time I look at it, given that that number is about what you would see in the general population for lifetime experience of a traumatic event. So trauma is prevalent both in national samples and in our own backyard. So, why do we care? So the reason that we care about this co-occurrence is that compared to patients who only have an opioid use disorder diagnosis, individuals with co-occurring PTSD are at greater risk for opioid and other drug use, greater risk for overdose, greater risk for worse physical and mental health outcomes, and are more likely to engage or to be utilizing health services. We know that medications for opioid use disorder, so methadone or buprenorphine, are the most efficacious treatments for opioid use disorder. However, patients with a co-occurring PTSD diagnosis typically experience more severe psychiatric and psychosocial distress. And although the data is unclear, we'll say it that way, whether or not that diagnosis affects treatment, buprenorphine or methadone treatment retention, or opioid use outcomes, if you're experiencing more severe psychiatric distress and more psychosocial problems, it is likely to make engagement or success in treatment more difficult. So let's talk about screening and assessment for trauma and PTSD in these settings. So why is it important to screen for trauma and PTSD in MOUD treatment settings? So as we've already shown, trauma and PTSD are common among individuals with opioid use disorder. Like, based on the estimates that we have available to us, we can estimate somewhere about 1 out of every 3 patients is experiencing some sort of PTSD symptoms if they're in treatment for opioid use disorder. So we have a high concentration of people experiencing difficulties resulting from traumatic events. Another reason it's important is that the co-occurrence of PTSD and opioid use disorder is associated with more severe substance use problems, higher rates of depression, higher rates of suicide, more psychosocial problems. And it's also comorbid with a range of physical health problems. So that could be cardiovascular, musculoskeletal, gastrointestinal, dermatologic, autoimmune, cerebrovascular. It's associated with all sorts of physical health problems. So these psychiatric and psychosocial physical health burdens are likely to impact patients in these settings. And given these greater health burdens, they're more likely to utilize healthcare services. So if we can address trauma and PTSD in some way, we're likely to, or there's the potential to increase success in MOUD treatment and also to reduce the health burden of these conditions. Most individuals with co-occurring opioid use disorder and PTSD, they don't receive treatment for trauma or PTSD. And so MOUD providers can be an important first point of access to mental health care. There are publicly available and empirically supported brief screening measures that I'll show here in just a couple of minutes that can be a potential worthwhile addition in MOUD treatment settings. They don't require a lot of time or effort to administer, and they can identify individuals who could potentially benefit from additional services. We also know that most patients with PTSD are not evaluated, and they're not often offered education or counseling referrals for mental health treatment. And so there's a real opportunity here to assess and potentially provide referrals for treatment. Many patients avoid talking about their trauma due to the uncomfortable emotions associated with that discussion. There's also some perceived PTSD-related stigma or feelings of guilt or shame that just make it less likely that patients will spontaneously share their trauma experiences or their related symptoms with providers unless they're specifically asked about it. So these screening measures are some brief assessments that can be completed in 5 to 10 minutes, can really provide a valuable opportunity for intervention. So just to give you a sampling, and this is some foreshadowing for the toolkit that we'll share at the end of this presentation. These are publicly available, quickly administered measures that for your consideration. So one measure that I find particularly valuable is the life events checklist for DSM-5. Many of these measures were developed by the VA. This is a 17-item measure, takes 5 minutes to administer. This is a self-report measure that identifies, it's like a trauma history. So it identifies the number and type of traumatic events that an individual has experienced. It doesn't assess PTSD symptom severity or offer the opportunity to provide a diagnosis, but it gives you a sense of, is trauma a part of the equation in this person's life and in their presentation clinically? These measures, these are some self-report screeners that I think are really valuable in primary care, MOUD, other clinical settings. We've got the primary care PTSD screen for DSM-5. Those measures, that data that I showed from the Chittenden Clinic, that is this measure. It's a 5-item measure. It takes about a minute or two to administer, and can provide a sense of whether or not it's a good screener to determine whether or not this is somebody who might be struggling with PTSD symptoms, and then you can parse out patients who could potentially benefit from additional assessment or potential referrals to treatment. Two other measures that I'll talk about are the post-traumatic diagnostic scale for the DSM-5, that's the PDS-5, and then the PTSD checklist for DSM-5. These are 24 item measures, take about 10 to 15 minutes to administer, and just really good screeners to determine whether somebody is struggling with PTSD symptoms. It's a good way to monitor symptom change. And again, you can use these measures to determine whether a patient would benefit from a more thorough assessment. And then for our mental health providers, there are some gold standard publicly available clinician administered measures that actually offer the opportunity to assign diagnoses for PTSD. So there's the PTSD symptom scale interview, that's the PSSI-5, and then the clinician administered PTSD scale for DSM-5, that's the CAPS-5 that I'm showing there on the left, that was administered or developed by the VA. These measures are 24 to 30 items. They take quite a bit longer to administer, 20 to 60 minutes to administer. And so this would be the type of measure that you might use in a mental health setting if you're actually trying to assign a diagnosis. When you have more time, this would maybe not be something you would administer in a busy clinical setting or an MOUD setting, but these measures are intended for use by a qualified mental health professional who have training in structured clinical interviewing and can offer the opportunity to assign a differential diagnosis and just really get more in depth in terms of the symptoms that a person might be experiencing. So these are some measures that are publicly available that we've included in our toolkit that we'll show at the end of the presentation today. Just some food for thought in terms of ways to screen and assess for trauma in various clinical settings. So moving past assessment, let's talk about treatment for a minute. What is effective psychotherapy for PTSD? Traditionally or historically, there's been this belief that patients have to achieve abstinence from substances before they start PTSD treatment. And so this has resulted in a siloed or a sequential treatment model. In other words, a person has to be successful in substance use treatment before we even want to talk about beginning trauma or PTSD treatment. The good news is that there's extensive research spanning the past 2 decades that indicates that PTSD treatment, when it's offered concurrently or at the same time, ideally integrated with substance use treatment, significantly reduces both PTSD and substance use symptoms. There has been this understandable concern among providers that if we try to do trauma treatment while someone is in substance use treatment, maybe it could exacerbate their symptoms, prompt a return to substance use. But the data shows that only about 16% of patients with co-occurring PTSD and substance use disorder experience an increase in their PTSD symptoms at the beginning of treatment. Those increases tend to be brief, short in duration, and they're not predictive of how people do in treatment. So the advice that I always give to people, if they are experiencing some increases in their distress when they're beginning PTSD treatment, is to stick with it, and almost invariably it gets better. And so again, when you compare people who experience those increases in distress when they begin, those temporary increases in distress at the beginning of trauma treatment, it's not predictive of how people do at the end of treatment. So stick with it, things get better. And there have been a couple of studies, or there's at least one, Lancaster et al. From 2020. They found that patients with co-occurring PTSD and substance use disorder, so patients with these co-occurring conditions, they experience more PTSD symptom exacerbations when they're only receiving substance use treatment. So that is when their PTSD is not treated, they experience more exacerbations of their PTSD symptoms compared to integrated treatments that address both PTSD and substance use disorder. So we have pretty good data from the past 20 years that indicates that best practice is to treat both of these conditions at the same time and not waiting for, not having to follow this sequential treatment model where we treat one disorder at a time. And that based on this data, both the VA and the Department of Defense have endorsed clinical practice guidelines endorsing these concurrent treatment models. So trauma-focused therapies for co-occurring post-traumatic stress disorder and substance use disorder are the most effective for treating patients with these co-occurring conditions. And when we talk about trauma-focused therapies, what I mean is these are treatments that use cognitive, emotional, or behavioral techniques to facilitate the processing of the traumatic event in which the trauma is the central focus or the central component of treatment. So rather than just trying to alleviate or ameliorate symptoms of PTSD, we're actually trying to give the person the opportunity to talk about the trauma and process it rather than just coping with the symptoms that result from that traumatic event. So according to APA and then VA, Department of Defense, the two treatments with the most evidence supporting their efficacy are prolonged exposure therapy and then cognitive processing therapy. More recently, there is some really exciting research related to the concurrent treatment of PTSD and substance use disorders using both prolonged exposure therapy combined with relapse prevention for substance use disorders. So this is an integrated trauma-focused therapy that combines prolonged exposure therapy with cognitive behavioral therapy for substance use disorders. So this is a really great option for patients with co-occurring conditions. So these are our gold standard evidence-based treatments that are currently available. There are all sorts of trauma and PTSD treatments available. I like to say there are no wrong doors. Many of these treatments, there's evidence to indicate they're efficacious, but these three treatments seem to have the most evidence for their efficacy and are endorsed by some guidelines that I think very highly of. So just to give you a snapshot of a couple of these treatments, prolonged exposure therapy, this is what I do in my research job, is evaluating the efficacy of this intervention in specifically among people with opioid use disorder. So this treatment is a behavioral intervention developed by Edna Foa, who actually just passed away last week at the University of Pennsylvania. And so it involves both imaginal and then in vivo or real life exposure. So in session, the person engages in imaginal exposure where they revisit, recount, and process their memory of the traumatic event. And that imaginal exposure, again, it allows them to process the trauma memories and then helps them attain a more realistic perspective of the traumatic event. Outside of the therapy sessions, participants engage in vivo or real life exposure to safe situations. We never put anybody in any danger, but safe situations that they avoid because of trauma-related fear. These encounters allow the individual, it reduces trauma-related distress and enables the patient to realize that those avoided situations are not dangerous and that they're able to cope with the distress that comes up when they encounter those triggers. Treatment, typically, if you're following the published protocols, consists of 8 to 15 sessions, 90 minutes long. There's some good evidence that you can shorten that to 60-minute sessions to fit better within established clinic models. And it is one of the most effective PTSD treatments available. On average, people who receive prolonged exposure therapy achieve better outcomes than 86% of individuals who do not receive this treatment. And so there are several papers, including one that I published last year, showing that if you implement prolonged exposure therapy among people who are receiving either buprenorphine or methadone treatment, there are promising signs for the efficacy of that intervention. Cognitive processing therapy is the other evidence-based treatment for PTSD. This takes a more cognitive approach. The idea with CBT is to identify dysfunctional or erroneous thoughts and beliefs related to the trauma, and then to challenge those cognitions. So this is more traditional CBT, trying to replace those dysfunctional or maladaptive cognitions with more functional and realistic cognitions about the trauma. This therapy focuses on thoughts and beliefs related to safety, trust, power, self-esteem, intimacy. And rather than talking, doing imaginal exposure like you do with prolonged exposure therapy, this intervention involves writing about the traumatic experience and typically consists of 12 weekly sessions. Similar to prolonged exposure therapy, we've got some emerging data from the past 5, 6, 7, 8 years indicating, including a paper that I published back in 2019, showing that this intervention, when implemented among people with substance use disorders, is associated with significant reductions in PTSD symptoms. And then finally, I mentioned COPE. So this is prolonged exposure therapy combined with relapse prevention for substance use disorder. This is an integrated CBT program designed for patients who have PTSD and co-occurring alcohol or drug use disorders. It addresses both conditions concurrently. And we've got some really great data from Sudi back at MUSC, as well as some colleagues in Australia, showing that this intervention is associated with significant reductions in PTSD symptoms, as well as substance use severity. Typically, it's delivered by one therapist, again, over the course of about 12 sessions. So a really nice tool for treating co-occurring PTSD and substance use disorder. There is pharmacotherapy for co-occurring PTSD and substance use disorder. We know, there are all sorts of medications out there, naltrexone, acamprosate, disulfiram for alcohol use disorder. We've got buprenorphine, methadone, naltrexone for opioid use disorder, our gold standard treatments for opioid use disorder. So a couple of SSRIs are FDA approved for the treatment of PTSD, but there are no approved pharmacotherapies for PTSD and substance use disorder when they co-occur. Typically, the pharmacotherapy for PTSD is less effective than these behavioral or cognitive behavioral interventions. But there is some research examining pharmacotherapies. The research that we have right now for pharmacotherapies for these co-occurring conditions have failed to observe significant clinically meaningful differences among treatment groups. And so it seems like the behavioral interventions are our best option, or behavioral interventions combined with pharmacotherapy. So some of the medications that have been examined that haven't shown much evidence include anticonvulsants, so that target glutamate and GABA receptors. The idea was that they might reduce substance use and PTSD symptoms. That hasn't really borne out in the data. Same thing with prazosin and other medications that might reduce stress responses, nightmares, cravings, and the effects of withdrawal. Those medications just really haven't separated themselves from placebo or control conditions. There is some promising data to indicate that medications that modulate the neuroendocrine pathways, so oxytocin, for example, they're currently being examined as these agents may have anxiolytic and prosocial effects and could potentially reduce craving, use, and withdrawal symptoms in this population. And so we do, that's sort of the state of research in terms of pharmacotherapy for these conditions. There was a recent large meta-analysis that found that medications for substance use disorder, when they're combined with these gold standard psychotherapies, can be really effective for these co-occurring conditions. So integrated trauma-focused therapy, so prolonged exposure therapy, cognitive processing therapy, when they're combined with treatment for substance use disorder, they are superior to other therapies examined in terms of reducing PTSD symptoms. From this meta-analysis, and this is from Denise Hien at Rutgers, and came out, they published 2 papers in 2023 and 2024. They found that medications for alcohol use disorder with and without trauma-focused therapy were superior to placebo in terms of reducing alcohol use severity. But if we're targeting the PTSD symptoms, when you take these gold standard behavioral interventions and then combine them with the gold standard pharmacotherapy for that substance use disorder, that's how those treatments are associated with the best outcomes. There are a couple trials that have demonstrated promising support for the efficacy of prolonged exposure therapy plus naltrexone for patients with co-occurring PTSD and alcohol use disorder. That was Edna Foa and her group in 2013. And then I've published 2 papers over the past 5 years showing that prolonged exposure therapy plus either methadone or buprenorphine for patients with PTSD and opioid use disorder. There are promising effects in terms of its efficacy for reducing PTSD symptoms. So we have good data to show here are, we have publicly available assessments to screen and assess for PTSD. We have decades of research showing we've got some gold standard treatments that work really well for treating PTSD. But over the past few years, we've had some research that shows that only about half of individuals with opioid use disorder who also have a concurrent mental health condition have received treatment in the past year for their mental health condition. Rurality is often identified as a predictor of this unmet treatment need, which makes sense. Poverty, workforce shortages, lack of reliable transportation, they present significant barriers to mental health treatment in these rural areas. And so these together, these barriers can translate to significant gaps in access to mental health treatment generally, as well as to PTSD treatments specifically among patients who are living in rural communities. So based on these gaps that we identified in the literature, we wanted to talk to people in our community, talk to providers in our community to find out what sorts of facilitators and barriers they experience in their practice. And so I'm going to turn the floor over to Lindsey to talk about what we learned from those listening sessions.
Thank you, Kelly. All right, can everybody see my slides? All right, good to go. So as Kelly mentioned, we really wanted to root the center's work in the lived experience of healthcare providers. So to that end, we had decided to conduct listening sessions with a broad group of healthcare professionals. So we did expert purposive sampling. The goal here was for us to get special individuals with specialized knowledge and experience across the continuum of care. We worked together as a team with CORA to develop our interview protocol, and we covered a couple different areas, but co-occurring PTSD and trauma was one of the focus areas of our protocol. We recruited individuals in 3 states, so Vermont, New Hampshire, and Maine. There was a registration process to ensure that everybody who was signing up for the listening sessions was practicing in a rural community. And we were really able to get a diverse group of healthcare providers working in different settings across all 3 of these states. The sample sizes across the states were also fairly comparable. We held all of the listening sessions over Zoom. Our past experience has shown it's easier to get really busy healthcare professionals in a room for these discussions via Zoom. And we did this over a year. So from May of 2024 through May of 2025. Each of our sessions had 3 to 6 healthcare professionals with a facilitator and a moderator. We held a total of 19 sessions across all 3 states. And then within those, we broke people out into breakout rooms based on the types of professionals that were in the room. And we overall spoke to 162 healthcare professionals in Northern New England. We recorded and transcribed all of these sessions, and we also had note takers in the room just to make sure we were capturing everything. For our analysis, we used traditional qualitative techniques, including team-based coding, where we did initial coding as teams to really identify analytic categories. At first, we kind of worked off of our aims and research questions, and then in our initial coding, we were also identifying emergent themes. So that's our kind of test coding. Throughout the process, we met as a team to compare codes and content and resolve any discrepancies and make sure we were refining our coding definitions. After all of the transcripts were coded, we worked to really take and sort these clusters of codes into larger overarching themes that represent kind of the broader patterns that we were seeing in the data. And we used that to help synthesize and interpret our results. So I first just wanted to cover some overarching themes, and some of this is going to, mirror what Kelly had discussed from the literature. So across all of our focus groups, we heard there were really high rates of co-occurring trauma and PTSD among individuals with substance use disorder living in rural communities. And there was a general consensus that rurality really magnifies the challenges of addressing co-occurring trauma and PTSD, and in particular, being able to really meet people where they're at, both not just geographically, but where they are in their treatment and recovery journey. And we'll talk a little bit more in my presentation about some of the infrastructure barriers that make this more challenging for providers. And as Kelly mentioned, obviously workforce shortages, persistent trauma, and in rural communities, particularly the inability to address health-related social needs, makes implementing trauma-informed care really a lot more difficult. And then, of course, a lack of trauma-informed care hinders professionals' ability to effectively address substance use disorder. So, as Kelly pointed out earlier, we're still kind of working in that historical model of sequential treatment, and providers indicated that they know that that's really not the best way to approach this, and not concurrently addressing the trauma and the SUD at the same time makes it more challenging. So we really identified 8 primary themes that were barriers for addressing co-occurring trauma in individuals with substance use disorder in rural communities. The first being geographic barriers. I'm sure this is not a surprise to anyone on this call, but long distances to access treatment, limited public transportation, make consistently accessing behavioral health services a real challenge in rural communities. This also leads into, a lack of just generalized access to behavioral health services. So patients are often waiting long times to get psychiatric evaluations or on wait lists to get into trauma therapy. So this really causes treatment delays and kind of disjuncture in the continuity of care, which also rose to the top as a high level theme. So fragmented communication, particularly between emergency room providers, primary care providers, and then those working in the mental health space, leads to these care interruptions across and hinders continuity of care, which in turn leads to less engagement and retention in treatment. And finally, on this page, while there was broad-based consensus that telehealth has improved access to some services, providers really expressed that addressing substance use disorders with co-occurring trauma is not best done over telehealth, and due to a lot of clinical limitations. And so while there's benefits to telehealth for this particularly complex population, it's not necessarily the best route for administering comprehensive treatment. Mirroring again some of what Kelly discussed from the literature, some of these overarching infrastructure issues, workforce shortages, high turnover amongst behavioral health providers, which is increasingly an issue, really address capacity in rural communities to address co-occurring substance use and trauma. Training gaps were also identified. So, a need for more training to enhance comfort across a broad range of providers. And we'll talk a little bit more in my next slide about how that really facilitates comprehensive treatment. Referral pathways and awareness of resources. So there was a lot of discussion about a lack of referral options for individuals who are maybe seen in emergency or primary care. These resources just specifically to address co-occurring disorders are very limited, and there's large gaps in the care continuum in rural communities. And there's also a lack of awareness as to where the resources are. It's hard for busy providers to keep up with referral pathways. And so, there was a call for kind of real-time information on where clients can be referred for more complex treatment for co-occurring disorders and trauma. We identified 4 primary buckets that actually act as facilitators to addressing substance use disorder in the presence of co-occurring PTSD and trauma. First is really integrated care teams. So having multidisciplinary care teams that involve medical personnel, behavioral clinicians, as well as peer and recovery coaches helps really coordinate not just the treatment side of things, but also addresses those health-related social needs that we know if those go unaddressed, it's really hard to retain patients in treatment. And they're critical to also reducing some of those barriers to access. Collaboration was really frequently discussed. So the desire for, when there's the ability to have warm handoffs to behavioral health providers, such as in a co-located model, which was also one of our themes here, really increases engagement on the patient side. It helps to reduce stigma. And provide a more comprehensive approach to addressing the complex needs of this population. So that need for collaboration and then co-location actually helps to enhance that collaboration, right? So in co-located facilities, there's enhanced care coordination, there's enhanced care transitions. It reduces the burden of transportation because clients can just make one trip to a specific location and address kind of all of their needs in that location. And then finally, more holistic integrated models that address SUD and trauma simultaneously. So as Kelly pointed out earlier, providers on the ground working in this space are calling for these kind of simultaneous treatment models that offer a unified approach. And that really helps improve not only access, but engagement and retention in treatment. We did in our interview protocol ask about training and resource needs, and what we heard was there was a need for more enhanced workforce training on how to address both conditions simultaneously. There was also a great need for just understanding PTSD and trauma overall, as well as more resources to enhance organizations and provider capacity to address co-occurring disorders, and that will help with kind of the lack of comfort that we heard from some providers. And that is, I want to make sure I say it's not a lack of comfort in wanting to address these issues. It's that not feeling like they have the resources or even the support in their organization if they come across a complex case like this to support them in providing the best evidence-based care that they can to that particular patient. And I'm going to turn it back to Kelly, who is going to talk about the toolkit. But I'm closing out with this fantastic quote from one of our focus groups that actually referenced how fantastic it would be if there was a toolkit to support them in this work. So Kelly's going to talk about the toolkit that we developed to support rural providers.
Thanks, Lindsay. Yeah, we couldn't have come up with a better segue if we had tried. So thank you for whoever offered that suggestion. So here's our clunky transition between slides. What we tried to do in response to what we heard from providers is to develop a toolkit that addresses some of these barriers that Lindsay just summarized. So this toolkit is live on our website. I'm going to try and go through this fairly quickly so that we have a couple minutes for questions here at the end. But our UVM CORA Co-Occurring PTSD and Opioid Use Disorder Toolkit is now available on the UVM CORA website. There's a link here. I think it was also in the links for the reminders about this webinar. So the goal of this toolkit is really to provide evidence-based PTSD assessment instruments, treatment manuals, training opportunities, and educational resources to treatment providers and their staff who are providing care to people with PTSD and opioid use disorder in rural communities. Just to give you an overview of what this toolkit involves. So we have about this toolkit page, it sort of describes the goals, provides a number of educational, it talks about what this toolkit is about. I've hit on that already. But really focusing on the co-occurrence of these conditions, providing resources to providers so that they can better provide treatment to people with these co-occurring conditions in rural communities. we have a tab on the toolkit called Assessment of Trauma and PTSD. So we provide information on why screening for trauma and PTSD is important in these rural treatment settings. And what I think is really cool here is that we got permission from both the VA as well as the group from the University of Pennsylvania. And we offer, these are publicly available assessment tools available for download from our website. So you can download the PDF of the assessment that if you are wanting to do screening or assessment of trauma and PTSD in your practice, you can download those measures from the toolkit. There's a guideline that we've developed for choosing from the available measures. It can be a little bit overwhelming when you got 5 or 8 measures and you're going, which one is going to best suit my practice? We tried to think through some of these questions and provide some guidelines for how to choose the best measure. And then recommendations for efficient and effective screening and referral procedures in the context of MOUD treatment settings in rural communities. So those tools are available, free downloads off the toolkit. We also have treatment manuals available. So as we saw in the feedback from providers, people feel like they need more resources, more training in order to deliver evidence-based treatment. So we at UVM CORA can provide rural treatment providers with physical copies of treatment manuals for these evidence-based treatments for PTSD that can be used to guide the delivery of the most effective treatments for PTSD. So there's a quick form that you fill out, let us know where you're working, who you're working with, and we can mail you physical copies of these manuals for gold standard treatments for PTSD, as well as that COPE treatment that I referred that integrates both prolonged exposure therapy with relapse prevention. So we want to send those manuals out to people who want them. We also, I'm really excited about this opportunity, maybe more than anything else, where our goal with this toolkit is to support mental health professionals who are providing care to people with opioid use disorder in HRSA designated rural counties. So the way that we want to do that is by covering the costs associated with taking these trainings. So we have 5 available trainings listed on the toolkit, 1 at the University of Pennsylvania, I think 2 through the VA. The developers of cognitive processing therapy offer an online training. The developers of COPE at MUSC, so that's the co-occurring or the integrated PE with relapse prevention, they offer online trainings through MUSC. You can fill out an application if you're working in a HRSA designated rural county and you're delivering these sorts, you're working with this population, we can cover the costs for you to attend these web-based trainings for these gold standard evidence-based treatments for PTSD. So trying to alleviate the burden of cost for attending these trainings. So there's applications on the toolkit. If you're interested in pursuing those trainings, we can reimburse you for those costs. And then we have I think a really impressive library of educational resources. So we provide links to information and educational resources on a variety of topics related to PTSD and then the co-occurrence of PTSD with opioid use disorder and other substance use disorders. We provide information and tools that might be particularly helpful for providers and staff in rural communities who are treating individuals with these co-occurring conditions, and all sorts of different topics on how to talk about trauma and PTSD with your patients, the more sciencey, evidence-based stuff if you're interested in that, as well as information for families, how to do this stuff in rural communities, how to address PTSD in individuals with substance use disorders. So we have educational resources for both providers as well as patients to help facilitate some of these conversations and referrals. On the site, we also provide some links for if you're looking for mental health providers who are providing these treatments, you can type in your zip code and find people who are in various directories to try to enhance some of those referrals and handoffs. So that is the end. That's the end of the slides. And I think Ginny's going to hop back on now.
Yes. Yes. Thank you. I will go ahead and share my screen again. And thank you so much, Dr. Peck and Dr. Smith, for this really impressive achievement in developing this toolkit and giving us all the background. Thanks to everyone who joined today. Before we get to, I hope we have time for a couple questions. We should. I'd like to go ahead and launch this poll. It should take us about 1 minute. So there you go. There's the poll in the center of your screen. And it's 4 questions. So it does really, really help us with our evaluation. So we really appreciate folks taking a couple minutes, or 1 minute probably, to fill that out. And I'll give you that time now. I'll give you a couple more seconds here. Thank you so much to everybody who filled this out. We appreciate it so much. I'm going to go ahead and end the poll. But if you did not have a chance to fill it out, that's okay. You can still get your continuing education credits. And as I mentioned, you will receive an email next week with the recording for this presentation, as well as instructions on claiming these credits. And we have also shared links in the chat with that information if you're looking for it now. We want to share that we have planned our next Community Rounds webinar, which is going to be happening on Wednesday, June 10th. And we will welcome Dr. Stephen Higgins and Tyler Erath to present From Evidence to Practice, Contingency Management for the Treatment of Stimulant and Other Substance Use Disorders. And if you want to go ahead and register for that now, you can do it at go.uvm.edu/cm for SUD. As you may be aware, UVM CORA is one of 3 rural centers of excellence. The other 2 centers are the Rural Center of Excellence on SUD Prevention at the University of Rochester in New York, the Rural Center of Excellence on SUD Recovery at the Fletcher Group in Kentucky, and the work of all 3 centers is highlighted on a shared clearinghouse website, which we've shown here, called the Rural SUD Info Center. And you can find that at ruralsudinfo.org. This is showing just some additional context for the information that we've presented today and explains how it relates to UVM CORA's funder. And if you'd like to get a list of references for today's presentation, you can contact Dr. Peck at this email. And I will now hand it over to Eleanor Broy, who has time to deliver a couple of your questions to our presenters.
Thank you. I'll now read through a couple questions we have. For Dr. Peck, what feedback would you offer to MOUD providers who are interested in taking initial steps towards implementing a more trauma-informed treatment approach in their practice?
Yeah, I mean, I think it is like I talked about in the slides, is I think first just acknowledging or recognizing that the majority of patients, or a large percentage of patients in these settings, have experienced trauma or dealing with trauma-related symptoms. And so thinking about not only how to set up like the physical infrastructure of treatment in a way that is trauma informed, but then also just thinking about like how are there some ways that we can assess and have conversations about trauma and PTSD in these settings. So these brief screeners, particularly like these 5-minute screeners, by administering those to patients, you can at least start that conversation of is trauma something that's affecting your life? How is it affecting your life? And then what do we do with that information? Because unless we ask directly, people are not often inclined to share that information spontaneously.
Sorry about that. That may be what we have time for. So thank you again, everyone, so much for joining. And as always, if you have any further comments or questions for our presenters or for us at UVM CORA, please contact us at cora@uvm.edu. And we hope you have a wonderful afternoon.
Thank you.